Yeah, we are on. Good evening, ladies and
Yes, sir.
gentlemen. Thank you very much for joining us again and with another webinar. This time it's on EOS guided biliary drainage, and the speaker is Vinay Dir. His name doesn't need much introduction. He's a big name in the endoscopic ultrasound guided procedures. He has developed guidelines on the biliary drainage, and he has developed model for teaching on endoscopic ultrasound. He is chairman of Institute of Digestive and Liver Disease of Rahija Hospital in Mumbai, India. We have been interacting with him on so many platforms. And this platform of PhD, he has been kind that he spared his time. This is his off day, his family day. And it has been very kind of him that he has consented to be one of the patrons, one of the teachers on this series of webinar, which I'm sure you know that we are already on to our 32nd webinar, and it's a series of total 40 webinars. We are left with another 8 webinars in the series, although we plan to continue on the same thing. But for today, Vinay, all yours on EOS guided biliary drainage.
Thank you, Said Saab. Thank you for the kind invitation. Said Saab, Saad, Khalid, all old friends. We don't meet in person often, but we meet in conferences very often, and the friendship goes for decades. All of you are excellent gastroenterologists, endoscopists, champions really. And my congratulations to the Pakistan Society of Gastroenterology and Endoscopy for organizing these weekly webinars. They are really educational and instructive. And I think this is a very good initiative. Also, keeping it live on Facebook, I think it's a great idea. The topic that has been given to me is very close to my heart. US guided biliary drainage. It's a wonderful technique. Of course, when I talk about it, probably I will sound a bit biased. So I think that is natural because I'm attached to it for more than a decade now. Um, but let's go back a few decades before EUSBD or EUS guided biliary drainage started. So we are talking about non-surgical drainage of the biliary tract. And the first technique to approach the horizon was PTBD or percutaneous drainage. Uh, it was in 1950s, 1952 that the first transabdominal cholangiography was described, and the technique of internalization of stent was perfected in 1978. So PTBD is the father or grandfather of all the non-surgical techniques, and a lot of what we do in EUSBD today is derived from PTBD techniques. ERCP arrived in the late 60s with McCune cannulating the papilla for the first time, and then Sohindra in 1980 placing the first transpapillary stent. It obviously revolutionized biliary drainage. It's almost now 5 decades that we are witnessing the growth of ERCP, and it's acquired a place which is called the gold standard for biliary drainage now. Now, EUSBD arrived at the scene when two techniques were already there, PTBD and ERCP. So, few enthusiasts tried EUSBD, and the natural place to try for gastroenterologists was where ERCP was not possible, where duodenal stenosis was there, or it was difficult to cannulate, or post-operative anatomy. So, Wiersma first showed us that via the EUS scope, we can obtain cholangiograms, and you all know Mark Giovannini. He did the first EUS guided biliary drainage in 2001. So, EUS-BD is the youngest of the lot, and it has been put to the maximum test compared to the other two techniques, and which is natural because it has arrived last, so it has to stand up. against the or with, not against, I should not say against, with the other two senior techniques. So just to remember a few people, Seldinger, devised the great Seldinger technique, which works not only in GI, but initially was planned for radiology, interventional radiology, and later has become commonplace in cardiology, gastroenterology, everywhere. Simple technique, but a great technique. And it is not well known that it was Itaru Oe from Japan who actually changed the scope to a side viewing scope, which was really good for ERCP. So he has done great work in technology for ERCP. And then, of course, we know Peter Willman was the first to devise a needle by which we can go outside the GI tract with the EUS. And then the story of the intervention started. So these are the people who gave us the initial fillip towards the three techniques that we have today. So if we compare the three techniques, looking at the access, PTPD is by and large, most experts do it blind. It can be done under ultrasound guidance, but almost all experts that I know do it blind. ERCP, I call it semi-blind because you are looking at the papilla, but you are not looking at the bile duct. So you have to imagine where is the bile duct, and we have a very good imagination, so we succeed most of the time. EOSBD is the only technique where you puncture the bile duct completely under vision, so you know where you are going. Difficult access with PTBD, I haven't heard. It's very, very rare. With EOSBD, very, very rare. You will access the bile duct, there will be no problem. With ERCP, difficult access can happen in up to 15% of people. PTBD, as you know, is accessed from the skin via the liver. ERCP is accessed via the access point is the papilla. And then again here, USBD scores because you can access the biliary system from multiple points, from the liver as well as from the duodenum. So from the stomach also you can puncture, or from the duodenum you can puncture. PTBD allows you an external drainage or an antegrade drainage, while ERCP allows you retrograde drainage. USBD allows you both antegrade and retrograde drainage. So you can do a rendezvous procedure and place a stent via the papilla. So that is a retrograde drainage. And of course, the antegrade drainage via various procedures. Um, Post-surgical anatomy, PTBD has no problems, EUSBD has no problems, plus ERCP succeeds in only about 60%. While gallbladder, again, ERCP can be done, but it has difficult access. So these are some of the points, not to say what is superior, what is not superior, but these are the three comparative techniques that we have for non-surgical biliary access. Since its description in 2001, EUS guided biliary interventions have proliferated. And the primary thing is the access point and the exit point. And as I told you, you can access the biliary tree from the stomach as well as from the duodenum. So you have certain procedures called access procedures, the rendezvous procedure, which can be done from the duodenum or from the stomach. You have stone extraction, not very common because ERCP is very good at this, EUS text. And then you have EUS guided biliary drainage that we are talking. So biliary drainage can be done transpapillary, which is the antegrade drainage, or transluminal. So transluminal procedures can be Collidinostomy, where you place a stent between the duodenum and the bile duct. It can be Hepaticogastrostomy, where you place a stent in the proximal stomach between the stomach and the left lobe of liver. And of course, you have gallbladder drainage. So these are all transluminal procedures in contrast to transpapillary drainage, which is EUS guided antegrade procedure. So a variety of procedures are there, and expertise in all these procedures takes time. The first 10 years after Giovanni described the procedure were taken to really improve the technique, standardize the technique. And then after that, if you see from 2011 onwards, fantastic literature, increasingly better and better literature about EUSBD has started appearing. Like ERCP, one of the most crucial learning points for EUSBD is scope position. So scope positions have to vary. So this is a scope position for a segment 2 drainage. This is a scope position for segment 3 drainage. This is a scope position for Collidinostomy. This is for rendezvous. And this is another one for rendezvous. So getting a good scope position, it's like if you play soccer, you have to learn to identify the angles at which the ball has to go. And this is the first thing that you have to learn. And when you are going to puncture, where is your needle going to go? Is it going through a vessel or not? And then once you have identified a good position, how to keep that position? Because a change of position can create problems in the overall procedure. So scope position is very, very important, just like how we were taught in ERCP. First, try to get a good scope position, then only try to cannulate. So let me briefly tell you about these procedures. Hepaticogastrostomy, as I told you, is from the proximal stomach. The puncture is done about 2 to 3 centimeters below G junction. Increasingly, we are using longer and more covered stents, 8 centimeters, 10 centimeters, 80% cover, 70% cover. So you puncture the duct, aspirate, confirm that you are in the duct, and then after that, dilate. Once you have passed the wire, you dilate and then place the stent. So the same procedure is followed everywhere. It's only the access point is different. So here, if you see, this is the needle coming. This is the dilated intrahepatic brain radical. You see the dilator is passing over the wire here, and then a stent is placed. In hepaticogastrostomy, you have to remember to keep a long length of the stent in the stomach, otherwise it can migrate. So 3 to 4 centimeters of stent should be kept within the gastric lumen. So pretty straightforward procedure once you have done a few, not a very complicated procedure. It should not take more than 10-15 minutes. You have if you have nicely dilated radicals. Antegrade procedure is the same. It begins the same way, but then you do not place a stent in the stomach. What you do is you pass the wire all the way down across the papilla into the duodenum or jejunum in postoperative cases, and then you place a stent just like how it is done in PTBD. So the stent does not come out. It comes out through the papilla. It doesn't come out through the stomach. So you see here we have passed a wire across the stenosis. You can see there are clips here. So this is a post-Whipple's patient. So you pass the wire, then pass a dilator. In this case, this is a 6 French cystotome. Confirm that you are in there, exchange with a stiff wire, and then place a stent. So this is called anti-grade procedure because we are going anti-grade exactly like PTBD. Actually, the procedure we have learned the details of the technique from the interventional radiologist. The advantage of anti-grade procedure is you are draining through the papilla. We don't know whether that's an advantage, but you get to use the normal stents that we use for ERCP, an uncovered metallic stent, which is much cheaper than the EUS specific stents which have become available now. So it saves on cost. The problem, passage of wire across the papilla is a technique which needs to be learned. It can be learned, not a problem, but it is a technique which needs to be learned. I'll spend a little more time on antegrade later. Collidinostomy is, as I told you, between the duodenum and a stent placement between the duodenum and the dilated bile duct. So you see the scope position, very different. Scope is in a long loop position, it's looking up. You have to puncture avoiding the cystic duct. If you should not puncture the cystic duct, and you should also see that your stent doesn't cover the cystic duct. Otherwise, there'll be a problem of cholecystitis. So the stent, because the stent is going to be a fully covered metal stent, you have to see that it is not covering the cystic duct. Same steps, passing the wire, passing the dilator, and putting a stent. In this case, we are placing a fully covered metal stent. Of course, you have EUS specific stents available now, which are, Axios is available, Spaxus is available. So straightforward procedure, provided you get a good access. So getting a good access and getting a good scope position, two important things before you puncture. Rendezvous, the utilization has come down increasingly. Initially, it was a commonly done procedure, but now we are using it mostly for benign indications where you are not able to get access either because of postoperative anatomy or because of some other reason. So here it's a mixture of EUS and ERCP. So you use the EUS scope to puncture the bile duct and pass a wire across the papilla. Scope position is again very, very important. You see how the needle is looking down? It makes your procedure easy. Once the wire goes across the papilla, you withdraw the EUS scope, keeping the wire in place, and then use an ERCP scope to go by the side of the wire, go to the papilla, and cannulate either by the side of the wire or pull the wire completely within the ERCP scope and then complete the procedure. So this is the rendezvous procedure. A little bit more about technique, since there is a mixed population here of attendees. I'll talk about technique. So see, this is the blue mark. These are the dilated radicals. So you have to angle your needle in such a way that it punctures a nicely dilated radical and that there is no vessel here. So this has to be imagined where your needle is going to come, and you should check that your scope is looking towards the hilum, not the other way around, because then passing the wire will be very difficult. So use fluoro to check that your scope is looking nicely towards the hilum. So here we have made a puncture. Once you make a puncture, always aspirate to see that there is bile. Once bile is there, you are nicely in place. Keep the scope in position or ask an assistant to hold the scope till you have passed the wire. Inject contrast. Now see where we have gone. We have gone here, and the radical is going like this, like this, like this. So these are the angles you have to manipulate from here to here, then up, then down, then if you use a segment 2 radical like this, then this problem is not there. You can go straight here and it becomes easy. With segment 3, sometimes this problem can happen. Guide wire passage, we use a terimo, a small terimo, which is short length, but a visiglide works equally well. See now the terimo has gone in the opposite direction. So you have to use your thumb and index finger to rotate the wire so that it changes direction. Once it changes direction, small amounts, 1 centimeter, 2 centimeter, you progress it while rotating at the same time. That way, you will reach the stricture. You see here, once you have reached the stricture, coil it and then use your dilator. So this is an important step, especially for antegrade drainage, passage of wire. You have to learn how to pass the wire. It needs patience, but it's a beautiful technique. See, this is an acute angle. So there can be a problem because the scope can go back. So you have to, your assistant who is pushing the wire has to keep the wire taut. See, once I have passed the cystotome here, the wire went in very easily into the duodenum because it has stabilized the wire. So here we are into the duodenum again. So identifying the angles, identifying which are the areas where there will be resistance, utilizing the help of your assistant so that there is enough tension on the wire will help you easily go into the duodenum. So once you have reached there, remove the terimo and replace it with a stiff wire because stent placement will require a stiff wire. So place a stiff wire and then remove the cystotome. After this, very, very rarely, probably less than 5% of cases, you will need dilation. Most of the case times you don't need dilation. In this case, because no contrast is going beyond. This is a patient of CA gallbladder. So we used a dilator. So we used a Sohendra dilator. See, again, this angle is going to be tough. We know it beforehand. So you have to be careful. The stent and the scope gets pushed back. So you have to, if need be, lock it and slowly pass and keeping tension on the wire. Your assistant will keep adequate tension on the wire so that you can push the dilator gently. Now we are at the stricture. It's a tight stricture, so you have to be careful. See, I am pushing it. If you see my scope position, I am trying to push gently, gently, and then it starts going. It goes across. Once the dilator goes through, stent placement becomes fairly straightforward. It's not a problem at all. So yes, this technique, if you compare it to collidinostomy or hepaticogastrostomy, mm, probably takes more time. And so many, you will not see many publications about antigrade procedure because it's a bit cumbersome. But I don't know. I love the procedure and I find a transpapillary drainage is probably I'm an old timer. I like it. I first try to do a transpapillary drainage either via a rendezvous or via an antigrade drainage. Then stent placement. There are some fine points. Again, this angle you have to be careful. And the stent has to bend at this acute angle. So your assistant has to keep a little tension on the wire so that it bends. Once it bends, then because we have dilated, it should go pretty straightforward through the tumor and then into the duodenum. Once it has reached the duodenum, you have to inject contrast to know where the papilla is because you don't want to put a long segment of the stent into the duodenum. So you have to inject, find out where is the papilla. So it looks like the papilla is somewhere here. So we keep about a centimeter and a half and then deploy the rest of the stent here. So this is an important step. Deployment is okay since this is a biliary covered stent. If you are not happy, you can close the stent again and reposition it beyond the point. You know, there is a point there. But most of the times, it is a straightforward deployment, just like ERCP. And some people will place a plastic stent after this between the stomach and the liver. I never do that because we haven't encountered any case of a major bile leak following antigrade procedure. So these are the technical details. Now let's come to the results, outcomes. Look at the studies with a lot of patients. I believe, and studies have also shown that you will need at least 40 procedures to gain 85 to 90% success rate. So if we look at studies with more than 50 patients, you have a very decent success rate in almost all the studies. It approaches almost 90%. And the complications also start coming down. Initial 10, 20 cases, do it under supervision of an expert, learn the technique, and understand the complications. The complications also start coming down after 40 to 50 procedure. Now, this 18.6% appears scary, but majority of these complications are mild and settle down in 1 to 2 days. Not to say that there are no severe complications, there are bile leaks. So in ERCP, we are scared of pancreatitis. In EUSBD, we are scared of bile leaks, especially with transluminal procedures. We are worried that bile will leak and hepaticogastrostomy. So the incidence of bile leak in large studies is almost comparable to the incidence of pancreatitis in post-ERCP patients. So overall is about 3.9%. Bile leaks can be managed. Some can be fatal, but vast majority of bile leaks are self-limiting. If you have placed a stent, nothing much will happen. At the most, some biloma, which can be drained. But sometimes you can have severe complications. Now, these are all pictures of very early times, 2006, 7, 8, 9, when the technique was getting evolved. So here you see a shorter stent is used for hepaticogastrostomy. And the liver is here, the stomach is here, the stent is floating in between. So this causes a leak. We have learned from these, we have started creating longer stents, which are covered 70%. So these problems are rare nowadays. They do happen, but they are rare. See bile peritonitis from the uncovered portion of the stent. See here, the stent has completely migrated into the stomach and there is a bile leak all around. So severe complications do happen, can happen, and you have to take your informed consent accordingly. How about stent patency following EUSBD? Again, large studies show that stent patency is almost equivalent to metal stent patency following ERCP, 266 days. So pretty good. We also have comparative trials. I will talk about them later. So we were the first to compare ERCP and EUS for malignant distal CBD obstruction. This was a retrospective study, a large study, but a retrospective study. And we showed that there was absolutely no difference in the success rate and adverse events of EUSBD and ERCP. This was a controversial study, but I think following this, a lot of people got ideas and three randomized trials have got published after that. So these are the three randomized trials, all small numbers. The Korean study is the largest study. Other two are small numbers, but they do show that USBD and ERCP are equally effective for distal malignant biliary obstruction. Actually, if you see the Korean study, the adverse events in the ERCP arm are higher than ESBD. It is not my personal experience, but this is a randomized study, so we have to respect the results. What about comparison with PTBD? There are two small comparisons. Again, they are not very large. One of the problems with randomized studies is that there are very small number of patients, so you can take it either way. So you see, there is no difference in success rates, but adverse events are higher in the PTBD arm, both early and delayed. See, reinterventions are significantly higher. So while technically it is possible to place a stent with both USBD and PTBD, adverse events seem to be higher with PTBD. There is a meta-analysis, not a high-quality meta-analysis from my friend Michel Kahale's group. 9 studies, 483 patients, considerable heterogeneity because there are different kinds of studies, different kinds of stents, everything. But the message is that USBD had superior clinical success, fewer adverse events, and lower rate of reintervention. The same message that was conveyed in the randomized trials. What about comparing rendezvous with pre-cut papillotomy? So this is another controversial study we published in 2012, and we showed that in patients with difficult biliary cannulation, US guided rendezvous and pre-cut papillotomy have equal efficacy. But if you are looking at a single session success, US guided rendezvous is better because many a times following pre-cut, we ask the patient to wait for 48 hours. So following this, there is another study published in endoscopy on the same topic, and they have also concluded that EUS guided biliary access decreases the rate of therapeutic biliary ERCP failure. So rendezvous should be utilized to optimize a single session success. So this is another point to remember. If you have difficult cannulations in your unit, rendezvous is a useful procedure. What about post-operative patients? You know, the standard thing is enteroscopy assisted ERCP in post-operative anatomy. And we all know, those who do post enteroscopy assisted ERCP, that it is possible. It is time consuming And it doesn't succeed in all cases. It succeeds in maybe 65 to 70% of cases. So this is a retrospective study from my friend Moin Kashab, where he shows that success is significantly higher with EUSBD. Complications are also significantly higher with EUSBD. These are most of the complications are mild. So at our center, most of the times for saving time, we end up using enteroscopy EUSBD in place of enteroscopy assisted ERCP. So one more such video you see here, dilated biliary radicals, segment 2. We are puncturing segment 2 here. I'll forward the thing fast. See here, puncture close to the hilum. So that is easier to manipulate the wire, aspirate the bile. See here, we have gone. This is the anastomosis, hepaticogastrostomy, benign stricture. You dilate the stricture, you can dilate it with a balloon, and then if need be, place a stent. In this case, we have placed a plastic stent. This is the Itoi stent. Very, very good stent, not available outside Japan, unfortunately. But this allows us to go in again and again. We can every time remove the stent, pass a wire before removing the stent, and do multiple procedures once there is a blockage or something. So this is a possibility. We have to see more studies, but benign strictures of the hilum can also be managed, and USBD appears a better option than trying to go via enteroscopy. What about hilar blocks? Just I think few days ago, our Thai friends have published a good study about combining ERCP with EUSBD. Right side ERCP, left side EUSBD. We call it series. Excellent study. And the message is the same as this message, that USBD helps. So if you have a complex block type 3, type 4, and you're not able to um, go into the left side easily, you can use USBD in such patients and there will be success. Of course, you can also use USBD for right side from the duodenum, but there are few cases and that technique needs to be refined further. So one more, this patient we had placed two metal stents via ERCP, thinking that we have drained it well into the right and left, but the patient had cholangitis. So we used an EUSBD. You see, this is a dilated radical here. We are passing a wire. The wire actually can go across into the into the duodenum. And this is a cystotome. You can see how dilated the radical is. We decided to do a hepaticogastrostomy and straightforward procedure. Patient improved immediately. So these are things where ERCP and EUS can be used together, complex hilar blocks. Patients with duodenal stenosis, this is I think one of my very old videos. If you see the date, 12 years old. This is a patient of cea head pancreas with duodenal stenosis, dilated bile duct tumor, taken FNA, and then change the scope position so that the scope looks upwards. Look at the bile duct, place a 19 gauge needle, aspirate, and place a covered metal stent here. See here, fully covered metal stent. And then once you have done this, change the scope, or you can use the same scope to place an enteral stent. So in the same setting, we took a biopsy, placed a biliary stent, and placed an enteral stent. Uh, Immediate palliation of both the problems, obstructive jaundice and outlet obstruction. We have now EUS specific stents. I showed you geoport stent. We have Spexis is coming up, and hot axios is already there for Collidinostomy. I don't use them much because of the expense, but they are excellent stents, very, very good stents. And studies have shown they are safe, they are efficacious. So if you have rich patients, by all means use it. One of the issues we faced early on was once we started publishing, lot of requests started coming in for training, and we didn't have enough cases because ERCP succeeds in vast majority of cases. So the cases were few to train people. So we started devising models. So this is a 3D model we devised for training in EUSBD. It was a recent model. Then we devised a hybrid model for EUSBD, and now we have an all-in-one model where you can learn not only EUSBD but pseudocyst drainage, gastrostomy, EUS guided biopsy, and lots of other procedures. So that all-in-one model we have used in our last conference, and people were very happy with that. So the question that comes is, should we use EUSBD routinely in clinical use? So if you have gained enough expertise, please use it. It's a very useful procedure. It reduces your referrals to the interventional radiologists. It makes your patient happy because you will finish the procedure in a single sitting. Your ERCP fails, immediately change the scope and shift to EUS scope, complete the procedure. But if you do not have expertise, please learn first because there can be severe complications. At few expert centers, EUSBD has replaced PTBD as a first line option after failed ERCP. So, PTBD has diminished considerably at our center. Probably in a year, we are doing one or two, that too for very advanced hilar blocks. Otherwise, all the other work we do with EUSBD. For post-operative anatomy, although we need better evidence, but again at our center, we are using EUSBD as a first line option. And of course, EUSRV rendezvous complements ERCP in patients with difficult cannulation, and we are currently using it primarily for benign indications. So rare, not very common, but we do use it. De novo EUSBD, now that there are three randomized trials, should we start doing USBD before ERCP? My answer will be no. I will need more evidence before I will say that you start doing USBD before ERCP. I think we need much better evidence than what is available. Right now, ERCP remains the gold standard for vast majority of patients, except postoperative anatomy and duodenal stenosis. Thank you very much again for the invitation, and please come to our center in Mumbai whenever this COVID episode gets over. Thank you. Thanks a lot.
Thank you, Vinay. Thank you for an excellent talk. It has been a brilliant session. Your talk was illuminating, and I'm sure there are lots and lots of questions on various aspects. One of the questions which has been posted by a colleague of ours, although you have answered, it seems in few years ERCP will be replaced by therapeutic USRCP. And another question, what is the risk of pancreatitis after transpapillary antegrade stenting?
Both are very good questions. So this question keeps coming, whether EUSBD will replace ERCP. So looking into the future is always dicey. Is always dicey. Based on current evidence, I would say ERCP is still the gold standard. Uh, but I know there are large randomized, multi-center randomized trials ongoing. I hope the results come soon. That will help us. And not only that, I think particularly in countries like India and Pakistan, cost becomes a major issue. So not only you have to prove academically that the procedure is as good as ERCP, you have to make it cost effective compared to ERCP. Now, ERCP is around for many years, and so the costing has come down. And the third thing is you have to create the expertise in the community. So ERCP now is available in the community at most places. So that expertise, to make that expertise available, will take a while. So there are lots of unanswered question regarding EUSBD replacing ERCP. Yes, it is a candidate as of now, but we will see how the future unfolds. I want the stents to improve. They are very, very good, but I think there is a lot of scope for improvement in the stents, EUS specific stents. I need the accessories to improve, but at the same time, the cost should come down. Then only it is a worthwhile procedure. Otherwise, ERCP is already there. Why should we replace it? So that was the first question. The second question is again a great question. You are going through the papilla, so pancreatitis will happen. In our studies, we did a study with Takao, Professor Takao Itoi, of more than 190 patients, and the incidence of pancreatitis was 2.5%. It does happen.
So it's roughly the same as in ERCP.
Yes,
I
yes.
have but Dr. Khalid has given a very nice talk on replacement of USPD to ERCP, and he has given this talk just a couple of days ago. Khalid, what are your comments?
So I gave that yesterday, actually, and I think we all are a little bit biased at the same time, but we really need a more evidence on EUS. And majority, Vinay, I think hopefully would agree, majority of this evidence which we have is on retrospective data. And retrospective is always not the best data. Uh, and also these randomized controlled trial, Vinay gave example of 3 of those randomized controlled trials. One was from our center, only 33 and 34 patients in each arm. And if you look at those adverse effects, 20%, more than 20% in EUS and 14% in ERCP. I have reservations, a lot of reservations from the randomized controlled trial, which was from Korea. And especially with regard to ERCP, I don't know the exact percentage, but they have a lot of failures in ERCP,
Agreed.
Hmm.
and
Lot of
that is
proportion.
not acceptable. And so that is really not acceptable and adverse events. So you need a good technique of ERCP really cannot be replaced by any modality. I strongly believe that. I do both of these and do day in, day out. And I still believe ERCP would never be replaced by EUS, especially from
So,
uh, uh, primary, as a primary modality. And the reason is like, I know these both techniques, they both came as a diagnostic initially, and then they both became therapeutic. Now, EUS, we still have a diagnostic, but we're making progress in therapeutics. ERCP is pretty much solely now therapeutic itself, and we don't do much diagnostic. There are few things where you cannot really, EUS cannot replace ERCP. One of those is a cholangioscopy. And especially with regard to cholangiocarcinoma, evaluation for these patients who could be a transplant candidate in United States. If there is a cholangiocarcinoma and you end up doing a FNA of that, you completely take those patients out of the transplant list. They won't be even considered for that, but you can do that with the cholangioscopy. You can do a biopsy, and they still would be a candidate for transplant. We really need a large randomized trials, and those who are listening, I think some of those are naive people and in the beginners. Others are really advanced in their like procedure skills. But when you do a EUS or FNA, don't consider that if you can do a FNA, you are just gonna be just doing out EUS bile duct drainage or pancreatic duct drainage. It's just a slam dunk. It requires a lot of expertise, a lot of skill, and if you have to, and the biggest issue we still are having is really a bile leak with these, and a bile leak could be much more problematic than really a post-ERCP pancreatitis. We need improvement, continue to need improvement. Both technologies are going to continue to improve. At the end of the day, they both are complementary and not really a competitors.
Exactly. And at the same time, Vinay has already pointed out that in India and
Yes.
Pakistan, we must consider the cost as well. The duodenoscope is though expensive, but much less expensive as compared to the EOscope. And the accessories have been standardized. The
Yes.
technique has been standard. Yes, yes, Sat, you want to say something? I know you're heading towards another nikah ceremony.
No, no. uh, okay. First of all, Vinay, like always, your talks, you make them appear so simple. Some things that's not at all simple or easy. Whenever someone is listening to you, it seems like what it's just a
Yeah.
piece of cake. And all credit to you. And I totally agree with whatever you've said. And Khalid, I don't see that, especially like Riaz said, there are a lot of factors here. Now, one of the issues that we have is it depends on how good you are in which technique you are actually promoting or actually trying to compare. And I think that's something that's reflected in a lot of trials, which you've already pointed out. A couple of things I wanted to ask you, Vinay. I know that you probably use six French cystotome more than a lot of other people who are still using the hard tip cannula or the special cannula that is used to puncture. Your thoughts on that, number one. And number two, these specific stents, while they are not available, we were using the standard partially covered, wall stents for our procedures. How do you see that, and do you see any major issues? While these other stents generally tend to be more expensive, and in my opinion, not really make so much of a difference. Your thoughts on both, please. Thank you.
Yeah, thanks, Saad, for those comments. So, first question, six French cystotome, very, very nice. I use it in all my patients, and I know some of my Japanese colleagues use the hard cannula, but it is because cystotome is not available in Japan. It's not that they prefer a hard cannula. It is just that cystotome is not available in Japan and in so many countries, six French cystotome. So they don't use it. It makes the procedure so simple. There was initially a fear of causing bleeding, and that fear is unfounded. There is absolutely no bleeding following a cystotome. It takes you one, two, three on your pedal and you're in. It's very, very simple. And it works as a good catheter to direct your Terimo or the Visiglide, whatever you are using. So by all means, if you have access to it, please use it. The second thing is again a very good question. Now, you don't have to use EUS specific stents. If you saw my slides, I haven't shown you a single EUS specific stent. Um, I am friends of all companies, but I do what I like. And cost is important in our countries. So, in fact, I'll go as much as to say that we have data. So, when it started, EUSBD initially, some of my friends used plastic stents, and when the technique was not perfect, and they ended up with bile leaks and migrations and other things. We have been using plastic stents in some of our patients. Um, Again, Takao is using plastic stents in some of his patients for last 3, 4 years now. It's a safe technique. It's an effective technique. So, by all means, once you are comfortable with the technique, so as Khalid told you, that once you are comfortable with the technique, please use a. There are people who are using fully covered stent also. There are people who are using partially covered stent. There are people who are using, and I know the results. So I that is why I'm talking here. Plastic stents are good. They are not bad. So I when I publish it, probably it will create a controversy again. But I'm telling you that cost is a major problem. It's not with Khalid. I know all his patients are insured, but in India
In
and
Indian
Pakistan
it's
and our other
investigation.
countries, we need to cater to patients who do not have so much money. And what do you do? If ERCP is not possible, do you not drain it? No, please drain it.
Vinay, you have been puncturing segment two duct quite a lot. And there's always a concern that we can soil the mediastinum and one can cause the mediastitis. Is there any trick to avoid mediastinum and to be sure that we are below the diaphragm?
So,
Before you puncture the segment 2 duct.
no, see, there is a system which is obstructed. There is bile in the system which is under pressure. The moment you puncture it, some bile will leak. There is no question about it. So if anybody tells you that bile leak doesn't happen, what we are worried about is symptomatic bile leak. So majority of our patients, when we puncture, will have pain for 24 hours. And that is because we are going through the liver capsule. Sometimes if you are puncturing segment 2, you are going through the diaphragm. And there is some minimal bile leak, which does happen. The good thing is, if you are successful in placing a stent, the pressure is released towards the papilla and the bile drains off, and it prevents formation of collection or a bilome. So the real fear that we have of bile leak is only when you have not placed a stent, the system is still under pressure, or when you have placed a stent which is not properly placed and you are probably worried that it might come out, if you have done a hepaticogastrostomy, suppose, and the hepaticogastrostomy stent suddenly moves inside. We have all had this situation. It suddenly goes into the liver. Now you have a hole and a high pressure system. So never remove your guide wire. Once you have placed the stent, deploy it fully. When you are satisfied with the position, then only remove the guide wire. Otherwise, there is a major problem. So if the stent moves in, you are always in a position to place either a plastic stent or another metal stent to salvage the situation. So bile leak will happen. Symptomatic bile leak, which is troublesome to the patient, is rare, provided we take these precautions. Place a good stent, provide drainage.
Okay.
Yeah.
Because it's much easier to puncture the segment 2 duct as compared to puncturing the segment 3 duct.
It
And
is.
the
But
guide wire is
the
also
only
pretty
problem
straight.
there is suppose, so when I puncture segment 2, I usually want to see that I puncture it below the G junction. Sometimes it is not possible to see. Sometimes you believe you are below the G junction, but you are at the G junction or above
Exactly.
the
Yes.
G.
Just
And
above
in
the.
that case, your stent is opening in the esophagus.
Hmm.
That can be a problematic situation. So be very sure. In fact, Hara, places a clip before he punctures. It is too expensive for me, so I never place it. But he places a clip so that he's sure where the G junction is, and he punctures below the G junction.
Mm-hmm.
So that is the only issue with segment 2. That sometimes, not always, sometimes you may have issues of puncturing above the G junction.
Yeah, and also always get a measurement where exactly the G junction is, and before I puncture it, and I see where my scope is. And Vinay has said that many times in the presentation as well, and he makes it, as Sadbhai said, looks very easy, but just it is not that easy. The single most important thing is like your scope should be in the best neutral position. Your scope shouldn't be twisted that you move a little bit and scope is going to be just completely out or displaced, and your body shouldn't be twisted, and get the best neutral position, stable position before you puncture. That's the most single important thing, and Vinay has said that and stressed that many times.
When there's
It's
a
just like ERCP. We learned ERCP hard way. That those
Yeah.
times scopes were very not so great as they are now. So we would have, at least when I learned, I don't know, when Saad learned, we had those, not the video scopes.
yeah,
So
we use complete. Yeah.
yeah,
I think
Uh,
the majority of us
we
would
were
have
and I
gone
hammered.
on.
I have no idea what you are talking about.
But
Oh, you were not born
Khalid,
then, Khalid.
Khalid,
No,
You were not
remember
no,
one
born
thing.
then.
Majority of
it
us
was
would have
a
been
joke,
putting on.
you know. it was really a joke. For 2 hours, we would be struggling, and my boss will be telling me, this side, that side. Now things are much, much better with ERCP, but still, the
But there
first
was
thing
one,
that,
Yeah.
yeah,
Well,
sorry, there
yes.
was one advantage. You are
Yeah.
the only one seeing, so you could say whatever you wanted.
at the same time, Khalid,
Yeah, yeah.
remember
Nobody
those of
else
us
saw
who have
it.
been trained on fiber optic, just look at our eyes. One of our eyes is relatively smaller as compared to the other one. Just look at us
Yeah,
carefully.
yeah, yeah.
The ones who have been
Absolutely.
trained on fiber optic and we have been trained.
That is a fiber optic.
And this for the younger colleagues who are in the audience, that the old timers who have learned the endoscopy on fiber optic and who have been doing the fiber optic endoscopy, uh, there's been a lot of strain on our facial muscles. There's been a lot of strain on neck muscles, and we did have, I should say, cervical spondylosis more as compared to people who have been trained lately. Although few of us have done better as compared to the other people, but still the nature uh, does pay a toll.
Yes,
Um,
yes, yes,
okay,
absolutely.
when there's a
Absolutely.
question from one of the audience, but you said that you replace your uh, floppy wire with a stiff wire. Which wire do you prefer amongst the stiff wires?
So any of the 035 wires is very, very good. There is no problem. You have good wires from Boston, good wires from Cook, any of the 035. So in fact, again, if you 025 VisiGlide is
Hmm.
also pretty stiff, but I like a 035 wire. So I replace it with Jag, I replace it with Dream, any of the wires 035 which are stiff, place it because, and your assistant has to learn to give tension.
How to manage, how to rotate.
Yeah, how to. So when I am on over a bend, he has to keep it tense. If he leaves it floppy, I will never go over the bend. So that
Do
small, small
do we
things.
rotate the tip of the needle as well when you have to direct the needle? Do you have to direct the guide wire?
It can be done rarely. Most of the times I use the tip of the wire. Sometimes you can do it, but once the needle is fixed, I am happy with the needle. And if it is nicely in the biliary radical, I don't want to change it. Only if I am worried that I am not in the biliary radical, I will do something with the needle. Sometimes, if your needle is too much in and you are touching the opposite biliary radical
Mhm,
wall, then
mhm.
you may have to withdraw it a little bit so that the wire gets some place to move.
On the other side. Uh,
Yeah.
Uh, So there is an
they started
other
from
needle
my
with
doctor. Yes,
there is
yes,
another needle with a rotatable tip now available from
Yes.
Medtronic, and
Yes.
so you can rotate the tip of it and angle it just like an angle tip Y. The
Hmm.
needle is that way too, access needle,
Yes.
and
Yes. They
for
bought
the
it from
specific
the
purpose.
interventional radiology. They have our interventional radiologists have that needle which
That tip,
rotates,
yeah,
and we had been asking for a long time to give us that needle. It particularly useful in rendezvous.
yeah.
Very, very useful in rendezvous.
okay, last question. We are into the last minute of our session. There's a question from Dr. Tran. How about the learning curve of USBD? You
So
already
I
40
think
cases in a
Khalid
day.
has already given good warnings. You should be good in EUS, number one. You should be good in diagnostic EUS. You should have done adequate number of EUS biopsies with 19 gauge needle. 19 gauge needle is a different ball game compared to 22. Yeah, when you use the 19, you know that it is stiff and the movements are not as good as for 22 or 25. So when you are happy with your experience with 25 gauge needle, I feel currently it is also important that you are good with handling ERCP accessories. That is because most of the things we are using are still ERCP. So you should be good with ERCP. Once you have achieved that level, then my suggestion is please go somewhere, spend some time, at least see a few procedures, 3, 4, 5 procedures, and then start at a place where you can do advanced work. So if you fail, there is possibility of a PTBD. So
True.
it should not be that you are in a small place where once you fail, there is a bile leak and there is no second option. So start at a place where you have PTBD availability. In case you fail, there is a drainage available. So with all these precautions, I believe that if you have adequate expertise in ERCP and EUS biopsy, you will learn it quick. You will need probably 40 to 50 procedures, which is a long time for USBD. 40 USBDs means it will be probably a year and a half
Lots
or
of
2 years maybe. Yeah, yeah, yeah. So it's a learning curve. But again, my personal feeling is that if you branch out the advanced fellows into two branches, one learns ERCP and one learns EUSBD. The learning for EUSBD is faster compared to learning for ERCP. That is my feeling because I have done both.
okay.
So Khalid, study for you.
I
So
think for ELCP,
it
we
is,
were
it is,
joking.
I believe ERCP is technically very, very challenging. And the primary reason is you are semi-blind when you're cannulating. So to
True.
learn to position your scope in such a way that your wire goes in the bile duct is quite a challenge. It's not easy. You have to have real imagination plus expertise of really small movements. So that way, puncturing the bile duct is no deal. I think if you compare one to one, learning EUSBD is easier than learning ERCP. But currently, don't do that and
And ELCP
learn
first.
ERCP and then go to EUSBD.
And
Naveen,
can I
you
suggest
want to say
something, Vyas?
Yes,
yes, sure.
yes.
If and when this COVID leaves us and things go back to normal, Vinay unit does an excellent USBD course. I think it's one of the best there is that I know, and I would strongly recommend anybody really before even thinking about it to go and attend that. And it's a good experience, good learning, and
Thank
um,
you. Thank
and
you.
some
Thank
some
you.
some excellent teachers and the best guys there are. So I think Vinay, with all that, I strongly agree that your hands should be, you have full control on your hands.
Hmm. Yes.
It's very important, and that's why I feel that people who are good at ERCP, because they have this knack of holding the scope and
Yes.
using
Yes.
the hands, and stability of the scope becomes even more important when you're doing these procedures. I don't have the experience that obviously these masters have, but that's what I feel.
True.
Yes.
Naveen, you
Yes.
wanted to say something?
Yes, thank you very much. Thanks, Vinay. Thanks, Vinay. Vinay,
Hi, hi.
we've got one of your fellows, Puneet Chabra, I think trained by yourself, is working with us these days, and he
Okay.
speaks very
Okay.
highly of
Okay.
you. So fantastic talk. I've just got a couple of questions to ask, if it's okay. In fact, one of
Yes.
them is, so our practice is usually limited to cholecystectomy. And hepaticogastrostomy, I think you've already alluded, and Khalid Bhai, you've already also mentioned about the scope stability, which I think is one of the major challenges when you're trying to sort of assess and puncture the ducts, ensuring the scope stays as stable as possible. So I don't know if you've got any tips to suggest that, especially in patients who've got a big hiatus hernia. And you've got a bit of an altered anatomy. So that's one of the questions. Second question was, when you started off establishing this service, how did you convince your IR colleagues, interventional colleagues? Because we've got a fantastic interventional radiology service, and they are brilliant in PTBD. So our rates of complications are much better compared to our colleagues elsewhere in the UK. So I'll be keen to know how you approached the subject and how did you manage to convince your colleagues. And one last thing, I mean, again, as I said, our experience is limited to collidinostomy and not hepaticogastrostomy. In terms of wire sharing, again, if you could elaborate how you avoid that from happening. So thank you very much again for a fantastic talk.
Thanks, Nadeem. Lovely questions, all of them. So the first one that you asked, what was that now? I forgot. Three questions.
Hmm. Naveen? You'll have
So
to.
So,
apologies. So let's start off. How did you convince your IR colleagues, please?
okay, so when we started USBD at our center, it was we have excellent interventional radiology people with us. Very, very good. We have no problems as far as their technique goes. But the problem was faced mostly by our patients. So what happens is today my ERCP fails. I call my IR colleague that you have to come. I have injected or I have not injected. I have not cannulated. Please do this. The guy is busy. He says, okay, I will come tomorrow. Now, in case you have already injected, you are very worried. This is a situation in Mumbai. I don't know how it happens. Then
It's
he
exactly.
comes next day and he places an external drainage. He says, let the system drain, and after 2 days, I will internalize it. So the whole process becomes a 3 or 4 or 5 day process. And I work in a private setting. So my patient is paying. So when EUSBD came about, we thought, why not reduce? So it was nothing to do with the deficiency in the IR service. It is just that we wanted to give our patient a more efficient service. The ERCP fails, change the scope, put an EUS scope, succeed, so that he goes home the next day. So that was the primary motive. And the interventional radiology colleagues were fantastic. The
Sure.
Now
And
I
the
remember
sharing,
your
why?
yeah, second question I remembered about the hepaticogastrostomy positioning of the scope. So we use flat position. So our patient, once I have seen the G junction, I turn the patient flat on his back. That helps me anatomically. And then I check with radiology where my diaphragm is, and I ensure that I am below the diaphragm and that my scope is looking towards the higher. I also check vaguely at the length of the scope. So generally in India, it is about 44, 45 centimeters, the G junction being 41, 42, about 2 to 3 centimeters below. The scope is little up, tipped up, so that my scope tip is opposed to the stomach wall very closely. So this is the thing which I aim to get. Uh, Patient flat, turn so that you get the left hepatic radical, tip up and see the diaphragm on fluoro and see your endoscope markings. So this is how I generally, and I think it works practically very, very well. We don't have to place a clip. In all, practically everywhere you will be in segment 3 situation if you do all these things.
Sure. Thank you very much. I'm conscious of the time, but if you could also elaborate how you avoid wire sharing, please.
Yeah, we have had lots of wire sharing. We have had lots of, because see, wire in our case, sometimes I move the wire in difficult cases, but most of the time my assistant handles the wire. So if you can learn to handle the wire yourself, that is the best situation, because you know exactly how much tip should come out. You know when to rotate it, because you are there. Your assistant may not be so much there. If he's good, he has done lots of procedures with you, then yes, you develop a fantastic relationship where he understands you. Otherwise, if you can use your right hand to push the wire gently. So what we do is we are very careful when the wire is coming out. If in the beginning only 3-4 centimeter of wire has come out, you are in a soup, because in case you need to change the direction, if it has gone in the opposite direction, you will have to withdraw, and there is a narrow biliary radical that you are in, so chances of shearing. So put in very small amount of terimo or whatever it is, and once you have about 1.5 centimeters out, first rotate it in the direction that you desire. Once you have got a direction, push it another 1 or 2 centimeters. and then again rotate it in the direction you desire. So very, very small incremental passage of wire is, and sometimes we do get excited. Oh, this is too easy, and we push. But then if it goes in some other radical and you have to withdraw, sometimes you're lucky, sometimes you're not lucky. So suppose you are in a situation where you're in a wrong radical and you have to withdraw. Again, it's not 100% foolproof method, but I withdraw while I am rotating my scope, rotating my wire. Very, very gently with tip and index finger, rotate and gently try to withdraw it. If you withdraw it fast, 100% shear.
Thank you.
So rotation is the key.
So main thing is wire shearing happens only when you pull the wire back. It doesn't happen when you go in. So that's the point to be taken out of this. So just go in maybe a few millimeters at a time and keep rotating until you direct in the right direction. Because if you have a big radical and you have to pull back, it's always better to pull back the needle with the wire, but you don't have that luxury majority of these cases because it's a small radical. So just don't push too quick, go slow and rotate the wire. Try not to have to pull it back because that's when the wire shearing is going to happen.
Perfect. Excellent. So I think it's already 7:30. It remains for me to thank Dr. Vinay Dir for sparing his time, for giving such a wonderful talk on behalf of all the panelists, on behalf of Pakistan Society of Gastroenterology, College of Physician Surgeons, Asian Endoscopic Ultrasound Group, and other educational institutes. I'm really thankful to you. And I'm thankful to all the participants for sparing time. At the same time, for our sponsor, Wilson Pharmaceutical, for providing us with a platform. Um, God bless you all. May God keep you safe.
एक फोटो ले लें यार, एक फोटो ले। साथ तुम्हारे यहाँ लाइट नहीं है क्या?
ये भैया वो
बैठे हैं।
निकाह के लिए चले। पिछले हफ्ते भी निकाह के लिए बात की।
Nadeem, are you there? Nadeem, are you gone? Ah.
I think Nadeem is gone.
No, he's there. Junaid, किधर है Junaid? Where is Junaid? He was very helpful today morning. Hi Junaid. अंधेरे में हो यार. Thank you very much.
लगता है जुनैद भी किसी शादी पे है.
शादी में है लगता है.
नहीं,
thank you very much. Really enjoyed. Thank you, Khalid. Thank you, Saad. Thanks, Gyas. Thanks, Nadeem.
Thank you, Vinay. All the best. Thank you.
Thank you.